I think we're ready to get started. Good morning, everybody. Welcome to the second day of Circulating Health. I'm Dan Hallin from the University of California, San Diego Communication Department. The session this morning is Media, Language, and Health Inequalities, Critical Anthropological Perspectives. And our two speakers, you have, by the way, in your packet, I think, does everybody have this? No, not everybody has it. Okay, so I'll go ahead and read the whole thing then. So Rosemary Beck is our first speaker. She's professor of African languages and literatures at Leipzig University, where she is also director of the Institute of African Studies. She combines linguistic anthropology with sociological and cultural studies approaches. She's published extensively in the field of Swahili studies, on speaking objects, popular culture, HIV/AIDS prevention, on urban languages, language and development, and recently language philosophy. Her articles have appeared in numerous edited volumes and journals, including Journal of Modern African Studies, Discourse and Society, and Sociolinguistic Studies. She's co-author of Communicative Sustainability, Negotiating the Future from the Periphery, and co-editor of Abdi Latif Abdallah, Poet in Politics. Did I get somewhere close to that? Okay, and the second speaker is Leo Chávez. He's professor of anthropology at UC Irvine. His research examines various issues related to transnational migration, including immigrant families and household, labor market participation, motivations for migration, and the use of medical services, and media constructions of immigrant and nation. His books include Shadowed Lives, Undocumented Immigrants in American Society, which provides an ethnographic account of Mexican and Central American undocumented immigrants in San Diego, California, Covering Immigration, Popular Images and the Politics of the Nation, which examines representations of immigrants in the media and popular discourse in the United States through the lens of magazine covers and their related articles. And his newest book is The Latino Threat, Constructing Immigrants, Citizens, and the Nation, which examines issues of anti-Latino discourse, struggles over the meaning of citizenship, and the role of media spectacles in society in relation to the politics of reproduction, organ transplants, the Minuteman Project, and immigrant marches and protests. So for those of you who are new, the procedure we've been following is to have both speakers finish their presentations, which will be 30 minutes long, and then we have ample time for questions and discussion after both presentations. So
thank you very much for this introduction, and thank you very much for this invitation to come to Berkeley and participate in this actually very interesting conference with so many different people from different disciplines. I'm talking myself in a field where I'm trying to bring together medicine, technology, and language in different ways, and I have not published on that topic as of yet, but I hope that I will be able to do that soon. The notion of biomediatization has been very helpful for me to think about what I will talk about today. And actually, I will speak about a biomediatized Ebola, a very early example of biomediatization, actually, since the 1970s, when one of the first outbreaks occurred in Central African Republic, I think. And it is surprising how little academic attention has gone to Ebola before 2014, and how, as compared to the role Ebola played in pandemic preparedness and bioterrorism scenarios. So there is really a difference there, and it's actually interesting to see the kinds of Ebolas we are talking about. And I will talk about a media medical hybrid, which is a Western biomediatized Ebola as compared to a West African Ebola. And I just want to show you very quickly what I mean when I say West African Ebola. In West Africa, Ebola was the invisible enemy, and there was really problems to understand that Ebola is real in the sense of having which kinds of real-world effects it would have, not only as enrichment for a few politicians, corrupt politicians, but also of people dying. It was also built on, or is set up on, memories of civil war, which you can see here very nicely, somebody measuring temperature with a temperature measuring device, which is really reminiscent of civil war scenes. We have Ebola as a collapse of public health. systems, which was already very shaky after the Civil War and before Ebola set in. We have a clear crisis of the state, where there is no trust whatsoever in that state, whichever, Guinea or Sierra Leone or Liberia. It is a crisis of care. We can see here a sick mother, or the daughter lying next to her sick mother, and how do you deal with this problem of not being able to care for those close to you. And finally, it is also a spiritual crisis, where we can see that people were buried or were burnt beyond the usual contexts, which disrupt the circle of life, which needs to be fulfilled by people giving birth, living, dying, being buried, and then this life cycle must be fulfilled. And especially prominent were problems of pregnant women dying, where the cycle of life was really confounded, because the baby has not yet been born and it's buried together with the mother, or it has been burned, and these kind of things. So this is a very different kind of Ebola I'm speaking about. I speak about the Western biomedicized Ebola, and I will come to that in a moment. I'm especially interested how between the dazzles of technology and the fact that surviving Ebola is a kind of a miracle owed to nothing else but one's immune system, from those two poles emerges an imaginary of a post-Enlightenment subject. It is a securitized subject, which is characterized by self and other control. It suffers a loss of voice and agency, and is thus depleted of its sovereignty and citizenship. And I claim that while post-colonial studies have long ago drawn attention to the loss of voice by the subaltern, securitization and exceptionality of the biomedicized Ebola extend this loss to the hegemon and to the human being in general. So it's all about what life itself is. So let me show you the biomedicized Ebola, or not. I just need to run this. How do I do this? I think it is clear this is Stanley Kubrick's Space Odyssey, and there is this other scene where you have the yellow spacesuit, where it's being cut off with his lifeline by the computer or by the spaceship itself, and that is the moment where the breathing stops and this yellow spacesuit tumbles through space. My second example.
Neil and Buzz, the President of the United States is in his office now and would like to say a few words to you. Over. That would be an honor. Go ahead, Mr. President. This is Houston out.
Hello, Neil and Buzz. I'm talking to you by telephone from the Oval Room at the White House. And this certainly has to be the most historic telephone call ever made from the White House. I just can't tell you how proud we all are of what you have done. For every American, this has to be the proudest day of our lives. And for people all over the world, I am sure that they too join with Americans in recognizing what an immense feat this is. Because of what you have done, the heavens have become a part of man's world. And as you talk to us from the sea of tranquility, it inspires us to redouble our efforts to bring peace and tranquility to earth. Okay. For one priceless moment.
Okay, I think the main catchphrase is here: the heavens have become part of man's world. And it is power, the most powerful person speaking here, not the spacesuits, just to mention that. And of course you would know this one. No, I've problems, sorry. Yeah. Do you actually hear? Sound is okay?
In a remote African jungle, a small monkey is captured. Bound for a pet store in America, the animal carries a deadly virus.
I know that some of us have doubts about what we're about to do. We'd be less than human if we didn't. But the fate of the nation, perhaps the world, is in our hands. We cannot, we dare not refuse this burden. I'm confident that each of you will do his duty. God forgive us.
Your town is being quarantined.
We got 19 dead. We got 100 more infected. It's spreading like a brush fire.
What are you talking about?
If one of them's got it, then 10 of them have got it now. And if one of them gets out of Cedar Creek, we have a very interesting problem.
If that bug gets out of there, 260 million Americans will be dead or dying.
I'm leaving with the team in an hour.
From the heart of a small California town
Damn it, Sam, I want to save these people same as you.
to the inner circle of power in Washington.
The most optimistic projection for the spread of the virus is this: 24 hours, 36 hours, 48 hours.
The greatest medical crisis of all time
We can't stop it.
begins.
Try to remain calm.
Many people are dying and are going to continue to die unless we find this monkey.
There will be panic the likes of which we have never seen.
There you are!
Attention, Portland residents, citizens of San Diego, residents of attention, Denver.
Okay. So, of course, this is the famous outbreak, Ebola discourse, which we all know. But, of course, there are more. We can see Fukushima. I'll have some more film maybe
Yeah,
later on.
okay.
Okay. So we just leave on the light. But, okay. So, of course, spacesuits appear also in other contexts where we have to speak about security and securitization. That is Fukushima, 2011. And very interestingly, in a reduced form, but also you can see they wear gloves and special suits and the mouth, whatever you call it, during the refugee crisis in the Mediterranean. And finally, I want to show you my last clip here.
P-A-N.
This is from an actual ETU in Liberia from 2015.
E-D. Okay, thank you so much. Now? Okay. Thank you so much. Let's go.
It's coming.
Okay. I think you can see that maybe my first comment is that what I'm talking about is maybe not about Ebola as a health problem or a health issue. Where did I write that now? Okay, Ebola is probably not a health issue, but it is an issue of securitization and safety and exceptionality and all those things, but not only secondarily about health. So I will be speaking in a very different way about this issue than Charles Briggs and Dan Hallin have done. Spacesuit, in all these variants, describes a politicized but protective technology which in existential ways mediates between the human being and his environment. It is a technology which promises the minimization of risk of death, of impurity, of contagion, but which requires the maximization of securitization and control of the environment, of the human being, and of life. And these images tell the story of survival in a hostile environment. And I was reminded of Helmut Plessner, a German anthropological philosopher, who defines the living being as the accomplishment of borders, that life existentially depends on the ability of living beings to negotiate the boundary between the inside and the outside. It is called Grenzleistung in the German version. The difference between living beings, plants and animals, and human beings is that the latter's ability to reflect on his life as resulting from such boundary making. It means I have a body and I am a body. It's always this double existence which you keep on reflecting. And verbal interaction, speech or language is one of the most prominent instruments to reflect on this double existence of the human being. So it is I want to add to that language theorized as expression of the intrinsic cognitive and creative capability of the human being since early Enlightenment and throughout the past centuries is what differentiates the animal from the human being. Now, looking at these examples of Kubrick and the moon landing and so on, the technologized boundary making as accomplishment of existence expands the reach of the human being, but comes at the cost of his distance from the environment. It has got to do with closure, right? In terms of, if we speak with Helmut Plessner. Remarkably, while there is a particular increase of agency thanks to technology, this systematically does not include verbal agency. Spacesuits don't speak. Yeah? I further frame my contribution here in the context of the critical study of humanitarianism that has sharply brought into focus the moral economy of life. Didier Fassin writes that the politics of life in humanitarianism, in humanitarian intervention, comprises life that risks itself by its free will, worthy to be saved at all costs, that of doctors and nurses in this case, and the life of Liberians, Sierra Leoneans, and Guineans as life that is at stake and is not to be saved at all cost. To those lives, this debate adds also lives to be encamped and lives to enjoy the rights of the citadel. So African people sick of Ebola are being encamped, and the medical doctors coming from the West have the rights of the citadel and to be repatriated. It comes with a right to recovery and lives who don't have the right to recovery. And I would like to add, these are lives saved thanks to technology. That would be the medical doctors, and lives which are recovered thanks to the immune system or powers beyond one's influence, because that is at the core also of Ebola, that Ebola has no cure, and you cannot save people. You can only replenish, you can only have basic health interventions which you can apply to sick people. So they just survive or they die. There is nothing else you can do, as compared to medical doctors and nurses and medical staff who is protected by this technology. So, as I want to argue in this contribution, what emerges from the decontamination sluices of the Ebola camps, those for survivors and those for healthcare workers, under the imperative of securitization and exceptionality, is a technologized, post-Enlightenment human subject. For the very securitized spaces of the medical emergency that unfold for both medical staff and patients through seemingly all-encompassing and excessive regulation and control of hygiene standards, as decontamination depletes the subject of voice and of speech and the ability to negotiate, and thus in a fundamental and general sense of sovereignty. So we can say the subaltern has language, but it does not have voice. We used to have voice. So now that's my core argument. From the sluices of decontamination emerges a subject which has no voice. Okay, so let me go a little bit into the securitization of medicine, and I have to already hurry up. Okay. What we can see is that medical staff is usually most exposed to the virus. Medical staff are caregivers, and the people sick of Ebola are highly contagious. They are also very sick. There is a lot of vomiting and bleeding and so on. So it is, in fact, medical staff which can become vectors of the disease, and they have to protect themselves and protect also the others. So while there is no specialization needed in terms of medical care, we need specialization in terms of protection, of this technologized protection. We can see that this has paid off. Médecins Sans Frontières reports that fatalities have been very low. Interestingly, we have from 5,000 expatriate and local employees, 28 were infected, 25 of them were local people, and 3 international staff. 14 passed away, so half of the staff which got sick passed away, and they were all not expatriate staff. The point here is that expatriate staff which gets sick is being repatriated to their respective countries, and in the Western health system you have like a 90% survival possibility, while in an African ETU it's about down to 40 to 50%. So here you can see very sharply emerging these rights of life, even amongst medical staff. So, let me see where I continue with this one. What happened in the course of the intervention with the spacesuits is that the spacesuit or this technologized hygiene practice moves, there is always a balance. It's a hygiene practice, and usually doctors would have these practices in order to protect the patient as much as themselves. But under Ebola, this shifts. It moves towards the safety of the medical staff. And there is a blog from a Red Cross nurse who wrote, the most important messages were, your safety first, stay healthy, don't hurry to die. So this is also part of this right of life. You have the right to not hurry. You are not dying, but you could expose yourself to death. And those people who are sick, they die anyway, or not. Yeah. We can see that this whoever has been wearing such a PPE, as they are called, you can see they're clumsy, they're heavy, there are risks attached to it because you are slow, you might pinch your finger with a needle, all these kind of things. You have difficulty speaking and hearing because you are closed off. It is very hot. You have like only something between 1 hour and 3 hours to stay in the ETU before you have to go out and decontaminate. And there is an interesting thing about control, because you need to be highly controlled under these. On the one hand, you need a routinization. You have to do these things on routine. You can't concentrate all the time. But at the same time, you also need to be controlled. And you are going into the hot zone only as bodies, 2 of you. So we have to keep an eye on your colleague. Yeah? And there are practices of self and other control. One of the self-control practices is to have a mirror while dressing and undressing to see what you are actually doing, so you can also control yourself. And it reminds me somehow of talk of Nick Calder yesterday of control and self-control. This appears here again somehow. Okay, so the importance of this kind of control, self and other control, we can see it with the nurse in Spain who was not properly trained, who didn't have a counterpart to help her to doff her PPE. So she removed her goggles with her hands still in her gloves. She removed it and she had an itch in her eye and she just touched her eye. And that was it. That was the moment when she got infected, when she infected herself. So we can see how important this mix of control and self-control and other control, how important that is. So for me, the core of this securitization debate and control is with the decontamination sluice, and I'm trying to get this up and running. And what you can see here is that in this decontamination sluice, everything is geared towards accomplishing decontamination. And you have a specific arrangement of the different parts. You have the buckets on the right side, you have the detergents on the other side, the disinfectants. It is a very particular routine, or it is a setup which is also verbally, there are also words belong to this kind of setup. You can see she says turn, she says open your arms, and the doctor knows exactly what she's going to say and what he's supposed to do. And she will say in a moment, remove goggles, wash hands. And the interesting thing here is that even the words which are spoken, they are not anymore here in order to give a particular meaning. They don't have a referential aspect. They have only this aspect of structuring the whole decontamination process. And that is, and it is highly controlled, and we can see it everywhere. It's the same thing, whether it's in French or whether it's in whatever context. That is how it is done, right? So this is the moment where I started paying attention to this idea that language or speech is an instrument for negotiation, actually. That's what we would think. But here it loses this function completely, right? Okay. So let me just continue a little bit with the manufacture of bodies in Ebola. I want to draw attention that this is not just a one-sided process, right? It is, on the one hand, we have the technologized body, and we have, on the other hand, the lumpen body, which constitute each other as bodies in Ebola. I follow here the idea of Stefan Hirschauer, who wrote a fantastic article about the manufacture of bodies in surgery, where he shows that in surgery itself, distributed actors work to function together in that assemblage to accomplish surgery, right? So I want to draw attention to with this image is one of the iconic images of the Ebola epidemic, where you can see there are the technologized bodies, but they require also a lumpen body, literally a lumpen body, somebody lying there on the ground. We don't know what is happening. I mean, we can see there is no stretcher around. It's just spraying this person or what is left of this person. But it's in this combination that we have to look at Ebola. It's a technologized body and the lumpen body, or as I want to say, maybe as I want to show in a moment, also of the body that miraculously emerges from the sluices of decontamination, those surviving Ebola. Okay, so we can see that there are different rights of life attached to those two partners in Ebola, right? So you have the technologized bodies, the medical staff, who has the right to be expatriated, who has the right to protect themselves, right? And we have the lumpen body, or the disease, the person sick of Ebola. And we can see that very interestingly in the Ebola treatment centers, where the moment a suspect enters into the center, loses certain rights to privacy. He's being put together with other suspects, and you might not have Ebola, but because you are being put together with the other suspects, you might get infected and nobody will do anything to it. So you lose certain rights, and then you're going into the hot zone. And it is clear that is the moment when you're getting a number. And the more sick you get, doctors would only speak about you as a number. And if you're very sick, you would find that sick people are being sprayed with disinfectant just as beds and tables and chairs. And it's only when the sick person starts to recover that he is being a number again, and then a name and a person, until he can leave on the other side the hot zone, right? Okay, so the transformation back into into normal life is one I want to just briefly show, at least this short clip. You can see what happens.
À droite, hein? On a donné les vêtements par là. C'est fini? Oui, oui, on ouvre la porte. Et voilà. On l'a dit. Et voilà. Voilà. Yeah!
Okay, these have been very emotional moments when people emerge healed from the other decontamination sluice. Of course, there are two decontamination sluices, one for the medical staff and one for the survivors. So one emerges as a doctor and the other one emerges as a survivor, and it's kind of a heroic moment of survival. But with the one is that one has benefits of the technology, and the other one the benefits of the immune system or of God. I mean, people would say God has saved me. So one is more on the Zoe side, if we want to speak with Agamben, and the other one on the Bios side, right? But still, they belong together in this moment of emerging from the sluices, right? Okay. What we routinely interpret as a stark contrast between the technologized body of the doctor and the lumpen body, which I mean in a very literal sense, turns out to be systematic with regard to the moral economy and the politics of life, which makes a difference between lives with rights and lives without rights. lives to be saved and lives to be risked, and so on. Exceptionality, according to an extensive literature and debate in political philosophy, is this is intrinsic to the constitution of the modern nation state. It's not, the exceptionality itself is constitutive of modernity and of the modern nation state because of its boundary-making capacity. And the differentiation between inside and outside normality is constituted in this liminal space where no longer law reigns, but the difference between lives with civil rights and lives reduced to their bare existence, lives subjected to this particular securitization discourse. The very political character of neoliberalism and globalization has exacerbated the ambiguities of humanitarianism and the concomitant politics of life, as Fassin has written about. Although implicit in this view, we often forget that the hegemon's rights are defined by the subalterns. Yeah? And we keep on forgetting that. We keep on forgetting that our rights in the citadel are defined by the loss of rights of the subaltern. And that somehow comes for me strongly together in this Ebola topic. Yeah? Exceptionality thus must be seen as mutual, interactively produced boundary space inclusive of us and them. So we cannot make this difference anymore between us and them. And if we then have a loss of voice of the subaltern, we can see here that there is a loss of voice of the hegemon as well. Yeah. Yeah, I think that's almost, let me see what else I have. Yeah, one of the, I mean, we can see that also that the lessons learned out of Ebola is not to speak about rights of life, but to improve pandemic preparedness. And we can see that already with, I could see that in Swiss hospitals, for example, where I did a number of interviews, or the Swiss Air Rescue, who have built up, who have developed a mobile Ebola transportation system for other pandemics to come, for other viruses to emerge. So we are not moving away from this from this trajectory, but we are moving more into it, right? Yeah, I think that's about what I want to say. We can still talk about it later on. Thanks a lot.
Oh, good. Well, first of all, I'd like to thank everyone, particularly Charles, for inviting me here. It's been a very interesting experience so far, and I'm looking forward to the rest of the day. To come to a conference so interdisciplinary. We're all sort of coming at the same question from different scales, I guess, and different kinds of ways of doing things, but we're all aiming to the same target, which I think is kind of interesting. Mine is sort of a case study of something I'm calling the immigrant diseasescapes, and just to remind everyone the way I think about it, because even though it's very similar to the way everyone else thinks about it, I'm sure I'm interested in the social life of images and media. By this I mean media images mean something because they are embedded in social and political narratives, myths, and discourses, and because they become critical players in the social and political life of a nation. In other words, media images are not separate from everyday material world we live in. Their value and their utility, which is going to become important, are related to their productive power, that is, the power to produce perceptions, ideas, prejudices, stereotypes, and to justify laws that govern conduct. Which brings me to what I'm calling diseasescapes. Immigrant diseasescapes, which is what my case study here is about, are discursive and visual images found in public discourse that frame immigrants and refugees as disease threats to the body of the nation. It builds on the previous discussion very, very nicely, and Adele's presentation yesterday. Let me begin with how I'm framing what I'm calling immigrant diseasescapes and how I'm trying to build a sense of understanding what they do and how they work. I'm doing this up front because sometimes there's not enough time to tell you, so I'll be giving you my conclusions as I go along in case I run out of time. When I'm using immigrant diseasescapes, I'm clearly, as Adele pointed out, referring and drawing on the work of Arjun Appadurai and his discussion of what he calls scapes that contribute to the global exchange of ideas and information. I am particularly drawing on, just to kind of elaborate a little bit more than she did, on three different scapes. Ethnoscapes, which has to do with the movement of people and cultures around the world, around the globe. Also, I'm interested in mediascapes, which deal with the production and dissemination of images and information. Mediascapes, of course, as we all know, help shape and construct the imagined world we live in. Finally, immigrant diseasescapes include idioscapes, which refer to the political ideologies of states, of governments, and power. Idioscapes are where you find contestations over ideas and terms such as democracy, citizen, nation, freedom, rights, welfare, moral turpitude, as we're hearing more and more today in the current discourse, borders, security, as we just heard, and what constitutes a threat to our very existence as a people, or a human race, whatever you want to call it. These concepts, drawn from Apodere, help me sort of begin to frame how I understand how diseasescapes are constructed through mediascapes as a way of framing immigrants, the ethnoscape, and the immigration debate in support of states to police and control the mobility of subjects in idioscapes. Immigrant diseasescapes become ideological armory in the battle to secure borders, to prevent diseased bodies from entering the body of the nation, as we're hearing so much now. There are 4 factors I want to emphasize that help me frame an understanding of immigrant diseasescapes in my case study here. So if I'll kind of lay these 4 factors out. One is that diseasescapes consist of signs, and these signs represent germs, plagues, parasites, bloodsuckers, obesity, diabetes, and multitude, and you'll see so many diseases, and immigrants, refugees, ethnic groups, racial groups on the other hand. These are all sort of lumped together. Alan Kraut, of course, used this idea to frame his famous book and discussion of medicalized nativism, and he pointed out how various national groups who come to this country were associated with certain diseases over time, particularly in the early migrations to this country, 1800s and early 1900s. The Irish, of course, with cholera. The Jews with basically the Jewish disease, or Taylor's disease, which was TB at the time. The Italians with polio. And probably one of the most heavy cases of medicalized nativism had to do with the Chinese, who were associated with so many illnesses it's almost hard to keep track of them. But here you see leprosy, smallpox, malaria, also plague, which led to Chinatowns here in San Francisco being targeted and closed by the military at various times in its history because they were seen as a source of danger to the rest of the nation. Here you have, right here in San Francisco Bay, our Ellis Island, basically, which would be Angel Island, a Chinese person representing threats to the nation because you see the Chinese are immoral, they're filthy, and they have disease. And they represent, at that border here in San Francisco, not to let them in because that's what we're getting. Even ads, to kind of show you, and I'm going to come to the contemporary in a second, even ads used this idea of medicalized nativism to sell things. We still do this, as we'll see. Here you have, how do we get rid of the Chinese problem? Well, the Chinese are rat eaters. Let's buy our poison. They'll kill the rats. The Chinese may eat the rats and die, or they won't have any rats to eat, and therefore they'll basically perish as a people. So we're talking about some images and their meaning and how this works. So I'm looking at here, to begin with, as I talk about this first factor, as you'll see, there's a lot of ideas that get bundled into immigrant disease factors. They consist of signs. Let me see here. They bundle a whole lot of ideas and a whole lot of signs that, in a sense, link images representing people or immigrants with broader ideas or narratives in a broader discourse about nation, immigration, refugees, terrorism, medical costs, impending disaster. I use the term bundled as a simple way to refer to a more difficult term, or not difficult, but broader term used by our friend Charles Briggs called intertextuality, which he uses to refer to the fact that languages often aren't separate and unique. They overlap and integrate and co-constitute each other. And in this case, I'm suggesting that basically language of the nation, the language of citizenship, of worthiness, of deservingness, of migrants and refugees, and the threats to the nation overlap with the language of well-being, health, disease, and medical threats to the body of the nation. A second factor I want to that helps me understand how immigrant diseasescapes work and become so effective in our societies is the idea of circulation, which relates to the very topic of this conference. These images, for me, circulation is critical because you can have one of these images, but if it's not circulating, it doesn't do anything. So circulation, for me, is critical to these immigrant diseasescapes. These images find their way into public discourse through the various media now at our disposal, TV, newspapers, movies, blogs, social media that we've heard so much about yesterday, which is different from really qualitatively and qualitatively from 1800s, early 1900s. We have so many more ways to circulate now some of these images, diseasescapes. And as these images circulate through various media sites, they are viewed, consumed, read, and interpreted. And here is key too, because as they circulate, they come in dialogue as images, but in dialogue with those who view them, read them, and interpret them. And that's where the meaning becomes constructed. So it's one thing to have it, it has to circulate, then it has to enter a dialogue. And so you have now, coming to the contemporary period, a whole lot of examples where immigrants are linked to diseases in the contemporary history. AIDS, we can't forget how Haitians were targeted. They were blocked at borders, they couldn't give blood. They were incredibly discriminated against. Paul Farmer even wrote a book on AIDS, and it's an accusation to kind of point that out. We can't forget the SARS epidemic. Around the world, people were afraid of the Chinese. Here, there was a huge discussion of closing the border to the Chinese and people from Hong Kong. Mexicans have been associated with almost every disease known to man, and many more that we haven't invented yet, of them including leprosy and others. You see it in various circulated in different media. For example, Lou Dobbs talking about blaming Asians and Latin Americans for leprosy, even though it was shown that his facts and his numbers were completely wrong. His reply was, well, I can tell you this, if we reported it, it's a fact. So we're coming to what facts really mean again in terms of this disease. Swine flu in Mexicans, who can forget that recent outbreak that occurred, and Mexicans became targeted at borders throughout the world. I knew people who were stopped going into China and put into quarantine because they were Mexican or Mexican American or Mexican origin or looked Mexican of some sort. So you have, more recently, 2014, the incoming number of unaccompanied children from Honduras, El Salvador, and Guatemala, and then mothers and their children. It didn't take long for them to be associated with disease, not just the fact they were escaping poverty, hunger, violence in their communities, but now they were disease-laden animals coming to this country, and you see it in all kinds of media. You see it in television, illegal border crossers bringing health concerns, virus outbreaks possible. They became associated with, of all things, dengue fever, leprosy, TB. It's just sort of almost, here they come, let's just say how many things we can associate them in this immigrant diseasescapes that seem to occur. They were blamed for enterovirus. Somehow that became associated with these kids coming to the United States. And of course, when they were put into communities to try and find some sort of safe landing space, people were already riled up and said, like in Murrieta right down here in Southern California, we don't need them, save our children from diseases. We don't want to pay taxes for them, hell no, go home. US citizens don't get free pass, why should illegals? And if you look at the spelling on this, I think obviously we need to spend a lot more money on education in this country. Almost every word is misspelled. Anyway, immigrants become associated with, and the Obama administration with opening the doors to people with STDs, AIDS, gonorrhea, scabies. Scabies is a major problem, and all kinds of things. It became very political discussion and discourse. We heard about Ebola. Ebola, as you saw in the movie, was a threat that people feared would travel very fast. It didn't travel faster than pegging Ebola onto people crossing the US-Mexican border. That was almost instantaneous. Ebola outbreak fuels concern over risks at the US-Mexico border. You started seeing it in all kinds of different media forums. This is our friend CNN. General warns of Ebola coming over the southern border, so it was military. Axel got into this discussion, right, about how the back door hits as Central Americans who are now infected with Ebola incredibly fast, start coming into the country. The government and members of our government start labeling these children as Ebola virus carriers. A new word's created called Ebolification to talk about how immigration reform can't be dealt with until we deal with the Ebola problem coming across from El Salvador, Guatemala, and Honduras. Suddenly, the year before last, there was an outbreak of measles at Disneyland. Who's to blame? Interestingly enough, once again, the children coming across the border who, in various forms across this country, they were targeted as people who didn't have any sort of programs to give them any sort of vaccines to protect our people from measles and other things. So this Disneyland outbreak was basically blamed by Rush Limbaugh and across the media on these kids. Even though, and I shall point out later perhaps, you can just take 2 seconds to get on the internet and show that 98% of people in these kids in these countries are vaccinated because they don't ask like they do here. And the problem turned out to be parents who took their kids out of vaccines, not these kids coming, because 98% of kids, they don't ask in Honduras, they don't ask in Mexico, they don't ask in El Salvador. The government says you're getting vaccinated. It's not a choice, right? But anyway, you have memes. Memes circulate through the media, especially the internet, and various sites that basically, don't ask that question, is there any evidence? They just start linking and blaming Obama, of course, for opening the borders on measles. Even in the presidential debates we heard coming up to this election, we had a candidate who was actually a physician, I hear, a so-called physician, claiming that measles outbreak had to do with the children of immigrants coming to this country. And I mean, I can just show you, I can just go on and on. They just loaded the cart. It's almost like, how many diseases can you name? Just put them out there and just see throw them against the wall and see what splatters. But then we get Zika, of course. Zika now becomes a major issue because Zika is related to a major problem. I mean, these kids, these babies that are born with the brains that are just not developed, I mean, it's a tragedy, right? But it becomes quickly associated with immigration and the border. Brazilians, blame it on Rio. We need to keep these germs out. Dominican Republic becomes a source of Zika virus. Here's a Dominican woman who actually looks like Michelle Obama, interestingly enough. On the head becomes herself a parasite, right? Because she becomes part of the body of a mosquito, right? And we need to keep them out. Human beings now become really the mosquitoes, the other, and the viruses and other actually mechanisms to pass viruses onto Americans. Here you have on the left, Zika virus foreshadows our dystopian climate future. And then on the right, Zika virus joins list of disease brought by illegals, associations, multiple sites, multiple ways of linking these things. So they become intertextual, right? They become tied into each other. This brings me, I've shown you so much of them, and I could do this for 2 hours. But I'm showing you this because my third factor that helps me understand this case study of immigrant disease scapes, which actually was already mentioned yesterday, is repetition. It's not enough to do it once. You have to repeat it, as I'm showing you, and just a little bit of the repetition, ad nauseum. Because what people need is to have a constant reminder of this association between immigrants, refugees, and disease, so it ensures that the topic continues in public discourse forever. It's hard to get rid of it. It's like a stereotype. If you say it enough, it's hard to change it because it's already embedded in sort of the mental structures that people carry around with them on this issue. Finally, the fourth thing that helps me figure out what's going on here is what I call use value. They acquire use value, these images in immigrant diseasescapes, because they're part of an economy of meaning. And I'm using the work of Deborah Poole here, who did a great book on race images for the last 400 years, dealing with Latin America and Europe, and how race was constructed as a type through images, and how it's the economy of value that's constructed in images as they circulate, and people develop these meanings in their discourses about things like race. In this case, I'm talking about health and immigrants. And it's useful then to think how immigrant diseasescapes have value because they're useful in a field of political contestation, specifically over issues of meaning. Meaning about the nation, meaning about citizenship, meaning about borders, and what it means to be a threat to our very existence as a people. That's what gives these things their use value in this economy of discourse. Immigrant diseasescapes become linked then in this way because they are useful in this broader political contestation over ideas. They're linked to things about like deservingness. Who deserves to be an American? Who deserves health care in this country? Who are the ones who are bad citizens? Who are the good citizens? Who are those who merit? And this becomes very clear in the kind of circulation of the immigrant diseasescapes in the media. Here you have illegal immigrant health care. We shouldn't be paying for these babies. They're coming from South America to scam American taxpayers. with these Zika babies. A woman has a baby with Zika virus to scam us, to take advantage of us. I mean, it's almost unbelievable that you could link it in that way in the public mind. But there are people who really believe people do these awful, live in these awful situations just to take advantage of us. I mean, we've heard this, of course, over and over from our new president, how we're taken advantage of. Zika virus. Here you have this awful situation. And how is it being portrayed in some of the immigrant diseasescapes? It's costing us. Where's the pity? Where's the emotion? Where's the humanity here? It's gone. The issue is, how much is it going to cost us? Who deserves our money? Right? You're paying for it. It's just pretty interesting. Immigrant diseasescapes then become a threat. Certain groups become a threat to the nation, which then now, in this political contestation over some of the issues, justifies policing, justifies surveillance, laws governing the conduct of immigrants, and security of the border. And you see this directly because the border becomes the place where we can control this problem. Because the problem becomes linked to our own biosecurity. This is an old story. This is back in 1994, an article in the Atlantic Monthly, and you see the cover, an article by Robert Kaplan. It's the world on fire, starting up in Alaska, coming down eventually to America. And the issue here is the world is on the verge of falling apart. It's a disaster, dystopian image of the world, and it's being led by the movement of people and their diseases. And it says here particularly, because I'm focusing now, I'm bringing you back to the border, because Trump didn't invent this, okay? I'm bringing you back to the border because immigrant diseasescapes have formed the Trump rhetoric, and it happened before him. So what does Kaplan say? The Latino buffer entity replaces the precise US-Mexico border. This new map is an ever-mutating representation of chaos that changes in response to migrations of people, explosions of birth rates, and disease. We have to do something, right? Immigrant diseasescapes want us to do something. They aren't just passive agents. They want us to get out there and be active in response to them. Here you have leprosy, and you have images of microbiology, view of images of viruses linked to words about immigrants, and refugees become this problem. Even as we heard just a second ago, in Italy they ban people because they're afraid of and here you have the same suits we just saw, because you have to protect the suit becomes a metaphor for the nation. Just as the nation, the body suit has a suit, the borders are the suit for the nation, the membrane of the nation. Here's a great one. I love this meme. Here's the terrorist on the right, and his counterpart is the mosquito on the left. But they're all things we need to worry about in terms of security, biosecurity, right? So the border becomes the place where we can focus our energies to do something about this, have policy in relationship to immigrant diseasescapes. Here, I like this one, no immigration. Here you have the border guards, and they're backing up because the guy at the border just sneezed, and God knows what he has, right? But you have other nice ones too. I mean, it gets so colorful. These people are very creative who produce and promote these images, diseasescapes. Look at this. This is really pretty. You have Ebola, enterovirus, scabies, TB. It's pretty. But the point here is you have those, and the border is where we need to draw a line in the sand. Here you have the nations of Latin America, and they're all being represented by all these funny words like Mexico becomes measles-sico, bubonic Belize, Honduras colossus, cholera mala, influenza Nicaragua, I guess, whooping cough-ama. I'm lost where they're at now. Ebola Republic, which is Dominican. I mean, it just goes on and on, right? The problem is the arrows. It's okay if those arrows didn't go forward. The problem is they're not stuck in place. They're moving north. And that movement north is the fear. So immigrant diseasescapes give you a sense of direction, give you a sense of where the problem is, and motivates you to action. Right? So they're very powerful things. Here you have the border. Funny, another one. People crossing the border with all these little viruses tagging along. We've got to do something at the border. Memes also take and reverse some of the rhetoric that you hear on one side, like no human being is illegal, and they'll switch it around and say things like, except for disease-ridden border jumpers. It gets pretty humorous, I guess, in some ways. Here's the border. We've got to do something. Why? Because it's coming to a city near you. HIV, tuberculosis, malaria, leprosy, hepatitis, dengue, Chávez. Who knows about Chávez disease? Yeah, I have a student from Mexico who's studying that now, actually, and she finds very few references to it in most of the literature and media. But you see the sense of buildup, the border as a pressure cooker because of these diseases are just multiplying. And so many of them, you almost can't keep track of them. It's just boom, boom, boom. And I love this one. Give me you're hungry, you're tired, you're infected masses, right? It's just sort of promoting this sense of idea. And like I said, it takes 2 seconds to get on the internet. But Obama policy, open border policy. Now those of us who study immigration, he's called the deportation president. He deported more people than Bush and anyone else. And yet he's claimed in relationship to the immigrant diseasescapes as an open border person. And look at the people. They're no longer people. They're biohazards. They're reduced from being people with their stories, their narratives, their feelings, their desires, their goals, their dreams, to biohazards that we deal with, just as we saw in the previous one, in ways that are very sharp, stark, and in a way depressing when you apply them to people. Here's one of the border, and it's the threat coming north, the redness, which is always power coming north to destroy our way of life. And so what my point here is, and I don't want to go on too many things, is that the border is, dreamscapes meet biopower at the border, because that's where governing and control and surveillance really has become an essential part of this rhetoric that we have in the world today in the United States. Linking disease to immigration, national security, and the U.S.-Mexico border is a call for action. It helps rationalize Trump and people who support Trump, really, to control the border. Because what they're really doing is not just keeping those people out of taking our jobs, but the very infections that are going to come here in a much less obvious way to attack our bodies when we're not even looking. So it's a very insidious invasion that needs to be controlled. And you see it over and over and over and over again. I could just keep going on and on and on. Protect our kids from these diseases, people shouting at the border. It becomes very hostile. It becomes very emotional. We don't want immigrants, they have tuberculosis. We don't want measles, we don't want Zika. It becomes, people are frothing about this because they're whipped up, right? They're whipped up through these immigrant diseasescapes. Donald Trump has said tremendous infection disease is pouring across the border. Which ones? I have no idea he's talking about. Details don't get in his way. But he wants to help. Part of the rationale for the border is not just trade, not just the fact that they're coming across to take our jobs, but we ought to protect the body, the nation. And you see it here, a nice little meme. Basically, I'm going to build a big, beautiful wall. When it comes to Zika, I'll make Brazil pay for it. The idea, basically we can charge other people to help protect us. But the thing is, people don't go out and look for alternative facts, if you want to call them that. They kind of think, well, maybe he's right. I'm seeing so much of this. And here's a cartoon that kind of plays on that. This wouldn't have happened if we had a wall on our border like Donald Trump wanted, and they're reading the thing saying Zika virus spreads from South America. It's like a joke, but that's, in a sense, part of the joke helps rationalize the attempt to build things like border walls, to control access, to deny access, to basically push people and let people know they're not wanted. And I'll come back to this idea, if I don't, maybe I'm out of time here, and help construct the abject, the discardable, the unwanted, those who feel that, and you saw this a lot in the last couple of weeks, what happened? Why am I not allowed to come in? And my final thoughts then, and I think this is really a good point here, is that history really decomposes into pictures, not stories. Walter Benjamin, great comment, right? And this is what we're seeing here. I'm not telling you history. I'm not telling you anything. I'm telling you these images that are alive in the public discourse. And, I'm just tracing them sort of historically, but it's not history, it's images. Linking disease to culturally charged issues like immigration, terrorism, deservingness creates a clash of alternative facts. And actually, there's a nice psychological study that I'm using also as well that showed people, and I'm doing a psychological study too as well, showing people images and discursive and visual, and then asking them how they feel about it. What do they think about it? And then a series of psychological tests about depression and belongingness and other things. And it's clear, these images, they aren't neutral and they aren't placid. People react to them. They get hurt by them. Or if you show them positive images, they get valorized. I mean, these things do have effects on the way people themselves, who are targets of the discourse, feel about them. A wary public, who is not the target, but the ones who are, in a sense, enabled to think about the objects of this discourse, turn to a very emotional reaction. They feel. I give talks, and I'll give a whole lot of data, and they go, you can tell me the data you want to. I know inside my gut the way I think. Don't bother me with those data. You're a pointy-head academic. Because they feel it. They have an emotional attachment to it. And I'm done in a second. And the problem here is that the public doesn't discern between this set of facts and maybe facts that, as academics, we think are more appropriate. Because they're hearing all this, and they're not going to take the time, as we heard yesterday, or even have the resources, perhaps, even though it's so easy with the internet now, to check. That's not their job, really. You also have a clash of goals. This is what I'm finding in the, looking at the immigrant diseasescapes. You have as academics, we're interested in accuracy. We like to contribute to knowledge through the development of new information that we do studies on. Those who promote these immigrant diseasescapes have other goals. They're not our goals. I'm assuming we have a brotherhood here. Their goal is to influence public opinion. Their goal is to keep unwanted immigrants out. They don't care what our goals are or our facts are. And that's the issue here. That's where immigrant diseasescapes become the point of contestation, not just over immigrants, but knowledge. Knowledge and its uses. Thank you very much.
Okay, so the floor is open for questions. Yes.
Hang on just one second, let me bring you the mic.
Yeah.
Hi, this question is for Leo. No, that was great. That was amazing, the images that you showed. It just made me wonder about situations where germs are fetishized or almost treated as desirable in a sense. I was thinking of, for example, around street food and conflicts around street food in India. There have been a huge notion of germs somehow contributing to the authenticity of street food, and then someone's ability to digest germs as an index of their belonging, or their, when people live abroad and then they go back, and then these jokes around, oh, now she needs to drink, filtered water, or, this notion of a body becoming more delicate by living abroad. And then I'm thinking of, tourists or, people who go, say, to third world countries, even from here, and then there's a kind of a heroism in a sense of we're venturing into the world of germs, to cure people of germs. And I don't know how that plays out. And that's border related too, in the sense of Indian, non-residents going back, and how much has your body changed? And then the immune system becomes figured in some other way, I guess, through that, a kind of a test. And I suppose it could even be a way of keeping experts out, not immigrants out. But also within the US, I was thinking of things like alternative medicine, or people who reject antibiotics, or there are all these subcultures around barefoot, being in the mud and things like this. So I was just wondering about your thoughts.
I agree with everything you said. I don't know what else to say, except that how we eat and how our bodies sort of become accustomed to our way of life does distinguish us from other people, and we use that as a politics of belonging, or a politics of identity politics. And how you belong to different groups. I mean, for example, there's some people who think they can't eat bread but yet they don't have the disease, right? My wife doesn't like bread for various reasons, and so it goes from people who actually have diseases, they can't eat certain kinds of bread. Those who don't want to eat it, and those who just feel like, oh, it's part of that, right? So that's a sense of belonging that you eat. Anthropologists, of course, have long used the idea that their bodies go through this process of rite of passage of getting sick when they go to the field. And then you get a couple of anthropologists together, first thing you talk about, I've had ascarid worms, I've had giardia, I've had dysentery, and whoever can beat the on which disease they've had basically is a better anthropologist, I guess. So if you work in America or London or someplace, you don't get those illnesses, not quite the same level. So it almost ranks you, right, how much suffering you've done in the world. So yeah, so I agree with almost everything you said. You probably suffered a great deal. I've suffered a great deal, so I'm a great anthropologist. No, well, there you go. I suffered.
Yes.
Hi. Thank you very much for two wonderful papers. I have a question about the construction of the unmarked abject and the way that the white body is constructed by these discourses, both of them actually, as infinitely susceptible, and specifically with reference to the proximity of drugs coming over the border. I mean, it was the Gulf of marijuana in that map that you showed. And so you have this sort of proximity of illicit substances and the people who carry them into the country, where the white body is constructed as infinitely addictable, or very, very susceptible, infinitely docile. And so I'm just wondering how this constructs, for listeners, their own identity. I mean, there's a long history of, the Chinese with opium, Mexicans with marijuana, and so you have races and ethnicities associated with illicit substances, and what that does for white identity in constructing its fragility and panic.
Yeah, well, it's definitely true, but I sort of point out, when the Germans came, they were part of the fact that they brought beer was sort of stigmatized. The Italians brought their wine, which is, those two things aren't too far from marijuana. The Irish brought whiskey, or as I say, what would we do on a Friday to Saturday night at the dorms of my campus? I mean, it's just things that were stigmatized. But the point you're making, I think, is that where's the unmarked body in all this? But is it really unmarked? And I had some slides I did show you of back in the late 1800s, early 1900s, as America became an empire. Part of the discourse was how our bodies it's marked. It's just a clean body, and hygiene is part of the colonial mentality, right? We were bringing cleanliness, which helps reduce germs, which helps reduce the spread of disease. So it was really unmarked. In a way, it was marked very clearly as the body that actually helps bring sanitation and cleanliness and a lack of disease to the world. So it is unmarked in a sense, but it's also clearly marked in my mind in many ways because it is unmarked. But the issue would be, why are we so? Why are we afraid? We're afraid because it becomes part of the discourse that allows us, I think, to frame what we want in life, which would be, in this case, for some people, to control borders, and they can use that as one of their weapons. I think that's
And I would like to add, actually, to this. I find it interesting to say the white body is unmarked. I mean, what I have been speaking about is that the white body is technologized, right? And it is as such marked by technology. Now, the question is this going to be the new unmarked body, or is, as I would argue, is it a new kind of subject? Yeah. So maybe it is getting marked. I mean, that would be my question. Is the white body now marked by technology, or is it going to be just a new white body? I can't answer that question, but it's an interesting way to think about it. Thanks.
Yes?
I have a question. Have a question that I'm a little afraid to ask because it may sound Trumpian. But is there a rational border in between this problem that we recognize as being very racist, I guess, and the question of when a bad actor is recognized in one country, Zika or Ebola or something like that, one of the bad diseases and so on, is it totally irrational to at least temporarily prohibit immigration from that country? Or is it automatically assumed to be a racist response?
I think we've done that in the past, obviously. The issue for me is not that there's a danger, because oftentimes there may be a medical danger. The issue for me is how people get labeled as an entire group of people. All Mexicans, all Dominicans, all Haitians, and so all Latin Americans, all people from China. And so the issue for me is, it's sort of like the current debate about the Muslim ban that we just had on certain countries. And to me, the analogy for me is going back to the Second Amendment. And the idea, or what we always hear, the phrase we always hear is, guns don't kill, people do. Well, it's the same thing. Religions don't kill, people do. Or a nationality doesn't bring a disease, infected people do. And so I think it's always good to keep that in mind, because once you ratchet it up and generalize it to a whole group of people, whatever it is you're using to frame them, then it's a different level for them. It's a different purpose. But if you have to keep people out because they are infected, you have to quarantine when they come in, If I was bringing my dog with me someplace, they quarantine it because they don't want to bring rabies in. Well, that's that dog, not all dogs. Okay, just to be clear. So yeah, sometimes you have to make decisions like that, that are tough decisions and deal with it. But it's better to deal with individuals, I think, than whole nations. But, Dr. Briggs in the back.
I just have to use the microphone. I'm actually going to do something which is in some ways illicit, which is to bring a member of the audience perhaps into dialogue. There's somebody here who actually faced that question head on at the beginning of the H1N1 epidemic, where some of the initial accounts that you showed were blaming Mexican and Mexican immigration for what was seen as an emerging epidemic. So I'm wondering if, because here you have some experience actually thinking about what will I do as the voice of public health in the United States in being able to think about, the long-term public health understandings of immigration, borders, and relationship to disease. And how did you because, as we've noted a little bit in some of the presentations, at that point immigration moved into a lot of the social media commentary on the mainstream press, but did not, after the first few days, dominate in the United States the mainstream press about, what is this epidemic and how is it moving. So I thought it might be really fun if you folks could potentially dialogue, having seen this from very different perspectives.
Thanks very much. Rich Besser. I was acting director of the CDC during swine flu, and the question always comes up, do you close the border? What's the value in doing that? And it's a step you only want to take if there's science to support it as a way of control. And it was a question I faced a lot early in swine flu. Why don't we close the border to Mexico? And as a science-based agency, we had done much modeling over the years to say, well, what's the value, potential value in terms of disease transmission in border closure? And there were certain scenarios where that could be relevant. We had planned on a scenario of a new strain of flu emerging in an island off Indonesia, where border closure might delay entry of that disease. Funneling through a limited number of airports and screening people might slow down entry and ease the pressure on our healthcare system. But the situation of H1N1, which I think you alluded to, or another discussion, it quickly became pretty clear that it was in the US. And once a disease is already in your border, closing the borders does absolutely nothing to slow further entry. And so I was asked on the news shows every day, why don't we close the border? And I have clips of that, but that's a different talk. But they would show images of overflowing Mexican hospitals, people in the streets of Mexico wearing masks, and say, I remember Diane Sawyer saying to me, and I said, well, there have been 2 cases in San Diego, there have been cases in New York City, there are cases in Texas. And they would show these images and say, so you mean to say to me that closing our borders won't delay entry because it's already here? And would use this skeptical voice.
You said it just like she says it too.
Exactly.
That's very good.
Yeah.
Has that pause and
I have flashbacks. And I would say, yes, we've studied this, and once it's already here, you could raise the question, why don't other countries close their borders to us? And would go through the discussion. And I was pleased that after going through that in a number of times, it no longer became the conversation. But when Ebola hit in West Africa, there were many people who were saying that Americans should not be allowed to go help because they'll bring disease back. Donald Trump said we should ban all travel from people from, I'm not even sure it'd be limited to West Africa, but from Africa. He didn't. And we saw across the country stigmatization of people not just from places where Ebola was transmitting, but from all of Africa. Children whose families came from Nigeria and other parts of Africa being kept out of school. And that kind of racism that spreads by labeling people based on disease. There are very few circumstances in which there's ever value in terms of disease control on closing a border. There were certain early outbreaks of Ebola in Africa where they would, where it would occur in a very isolated village. where there was value in putting a perimeter around that village to reduce travel. The West African case, that was never considered because you had it breaking out really where three countries intersected. And so it was absolutely impossible to isolate an area of disease transmission. But very rarely is there any value in that, but it's people's initial response. In the US, people were calling for West Africa to be shut off, even though if you study air travel patterns or anything, it would have absolutely no value.
Yeah, just a couple of quick points. We used to use the phrase that germs don't carry passports. So it's sort of like, how would you stop it? But I just want to amplify one of your points, and that is, that one of the issues for me is how come the maps always show the flow north? Because swine flu, it turns out, originated in the United States, right. But we blame quickly Mexicans. When I was doing work back for my first book in the 80s in San Diego, and I'd go to these migrant camps where people were living in bushes under the trees, and I'd be having a beer with some guys on a Sunday, and these guys would be laughing and following these women. And I say, what's going on? Well, I said, the prostitutes are here. Because these are single men, they got paid, they have a lot of money, and this is a time when HIV and AIDS were just coming into it. These people would be from rural villages in Latin America, particularly Mexico, which would have decades before they ever came in contact with AIDS. These guys would get HIV and AIDS, take it back to this village, and infect their spouses, infect their girlfriends. And that was from north to south. But yet we always conceptualizing that we're the pure body, we're the ones that are being infected by them, rather than sometimes things start here.
And we love to label a disease with a country. So the flu pandemic of 1917-19, the Spanish flu pandemic, there's some evidence that originated in Kansas.
There you go.
So, but we think of it as Spanish flu, and that's very, very stigmatizing.
Julia?
Thank you for the fascinating panel. I really enjoyed it. So, Rosemary, I have been thinking about your talk, ever since, and it was a very powerful critical analysis. But critical analysis, at least to me, it always begs the question of how could we do it better? So, in this particular case, unless we think that in this case you showed pictures of Doctors Without Borders going there, that they go only to keep the disease in a particular location and not, deliver it to the West. So if we accept the premise that they actually go there to enable some kind of healing, enable those scenes of emergence of subjecthood that you described once, then the question is how could we have a different scene? Obviously, you can't give everybody a spacesuit because that wouldn't enable healing. So I keep thinking of how could it look different than the images you actually showed here, and is there an inherent scene that would look this way anyway, or is there a way in which you can imagine a scene of going and trying to support healing from Ebola that would look visually substantially different, that would eliminate these concerns that you have?
Well, no, there is no different way of looking when you work with Ebola. If you look at the old outbreaks from 2004 or even earlier than that, we can see that you don't always need to be highly technologized, as we can see the guys here, right? If you look at the old outbreaks, it's not that, you're not that blind and dumb and all these things. So there could be less, this has been one of the criticisms with Médecins Sans Frontières. But basically, you have to protect yourself, and that is very clear. So I think I don't see how it could really be different. The problem of this kind of analysis is that the individual people who are going there and actually are helping, they disappear behind a kind of a structural level of analysis, and that, of course, happened in my analysis as well. Because of course, Doctors Without Borders, if you go there, I know that Doctors Without Borders would only have 6 weeks people having 6 weeks in the hot zone, because it is emotionally and psychologically very hard to do that, to have hundreds of people dying around you. And it's kind of a mechanism to protect yourself, to give these people numbers and, and let them go and bring them back by means of numbering and naming, for example. Yeah. So there is nothing to blame those people who are going there, but we need to pay attention that there is no thing like happy helping. It always comes with the structural restraints of the European doctor having the rights to go out and come back to the citadel, Europe as citadel in that sense, while the person, the subaltern, does not have that right. Yeah, he's being kept out with all kinds of arguments, reasons, homogenizing stuff. Yeah. So we have to frame all these, even the humanitarian interventions, in this context.
Can I add something here? Because this was something we looked at pretty carefully. I think that the Ebola is a really interesting case for thinking about this, because the story lasted long enough that the news coverage changed a lot. And you could see it in the visual images. So I remember we were kind of watching it. At the beginning, the visual images were these ones that really objectified the black body in a very extreme way. So you would see exactly what you saw there, the decontaminating the body, and always the caregivers at a great distance from the victim, and no agency on the part of Africans at all. But the images changed. I mean, literally, you could see the caregivers and the victims, patients, getting closer together, I think, in the images. And you could also begin to see then images that involved agency, so that there were black caregivers who would see without the suits, or the African survivors who you would see without the suits, and similarly in the way the stories were written. Initially, they were very patronizing about the Africans who were resisting the introduction of Western medicine, and then they got more complex later on. And I think it had to do with both the journalists and the Western caregivers working with people longer, and and beginning to have a more complex view of what was going on. You would like to think that the next time around something like this happens, there will be a greater consciousness of the kind of stereotypes that are involved in the images and the and the writing, but I'm not sure that that's what will happen. But it did last long enough for considerable change to take place, I would say.
But I just want to add that when I speak about the technologized body, and if you look at the images I showed, in these spacesuits, in these PPEs, there are of course also African people, and I don't make that difference.
But you can't tell.
No, you can't tell. Yeah. That's exactly the point. But that is why I don't make a difference between African people and technologized, people. Technologized body. The body inside can be of any color, any background. It makes the difference is when this person gets sick, whether he's being repatriated to the European or American health system, where you have much better chances of survival, or not. Then there is a difference. But
are you telling us to stop?
No, I want to ask a question.
Okay, great.
I think I loved your paper, Rosemary, and it really was wonderful hearing it right after Mohan Dutta's yesterday, because to me it was like the extreme case of that broader phenomenon he talked about. And so in a way, although we can't see a practical alternative necessarily to what you've described, it is symptomatic of a much broader problem that I think we can see and imagine alternatives to that technologized self that comes from the West, that that parachutes in, that has the expert knowledge. And so I just wondered if you had any reflections on kind of zooming back out from this specific case.
Well, I was just thinking that datification also has no alternative. Or do we? You were saying that yourself yesterday, that datification sounds so negative and all these things. So actually, that's the same problem. I don't have an answer to that, really. Yeah. We are speaking about processes which the individual, or where we don't have control over it. Yeah. Datification happens. Yeah. And this kind of structural change from a loss of voice and the change of the imagery what a human being is. Well, maybe you can help us there.
Yeah, Nick had his hand up, so let's.
Yeah,
I mean,
please.
it's very compelling, and yeah, I love what you said. I mean, it's a devastating landscape of the disease scape. But of course, escape obviously always implies something's not being in escape. And as you said just then, and I was thinking about it too, obviously the fantasy of the pure national body, which doesn't have certain ethnic characteristics. It's an entire fantasy. It doesn't exist anywhere. Now, what I'm interested in is not how is that fantasy sustained? And obviously sustained not by the sending out of images, which we know a lot about. We know about the abject. That's familiar but depressing territory. But what I suspect we know less about is how processes that could challenge that fantasy are suppressed. I mean, Richard gave a good example. You had knowledge to say it was a pure fantasy to say that America was not already sick. And you had the skill to put that into the public domain. But that was relatively rare. How come that in other cases where that knowledge also exists, somehow it doesn't figure that way? It's blocked. People don't feel able. That seems to be an important part of what we've got to look at. We know about the abject, but what we do not know is how this damn fantasy survives. Even though it shouldn't survive, it's often in direct contradiction to people's actual experience in their doctor's surgeries.
Right. Yeah, that's a great point. That's like I would label that need for future research probably, because it really is. How does that happen? And I guess all I can think of is those who produce and promote the dreamscapes I'm talking about. Who would produce the other side would be us, but we have other goals. We got publication, we got our next merit praise, and so we critique. But we don't necessarily produce at that level. We produce at another level, right? Because our production is geared to what merits for us, has certain autocracy we're working on. If we spend all day producing counter dreams and counter dreamscapes, some people would say, well, that's really not a good use of my PhD or my good use of this. We should hire somebody to help us do that. Which maybe, why don't we do that? How come we don't have in our centers people being organized to do that? We have some great centers of CDC has great sources of information. Even some of the immigrant think tanks on the liberal side have good think tanks, but you don't see anything at this level of production. So the issue, like you're saying, is why? Why did we pull back from that engagement when other people are so involved in that engagement? I mean, to me, I find these images almost beautiful because they're clever. Who comes up with this stuff? Right?
But don't you know? But then you would be talking about the kind of scientific journalism, right? I mean, but we have that, don't we? I mean,
we need to wrap up. So let's take Clara's question and then we'll wrap up.
Thank you both of you. Great talk. I put some thinking inside because, like you said, somebody's are to choose sacrifice themselves, and others are object of sacrifices and dirty work. But I wanted to call the attention to that in education, in academic, there are many people that are right now putting up those images that are being. I remember that I was in the School of Medicine in San Diego, and a professor of medicine was talking in an auditorium of 500 students, and he said, "You want to study Shigella? Go to Guatemala. You want to study that? Go. You want to study Ebola? Go to Africa." And that sense is labeling. And what is this population of students that are learning? They are learning to stigmatize. See what is talking about mediatization. What could be happen with all of these journalists that now they want to be someone based at have the foundation of their career and make sensationalism. And what is the way of making sensationalism? Is just to increase or facilitate this amplification of those stereotypes. That is a comment that I wanted to make, and you think.
Okay, and so I think we should wrap up. So we'll be back at 11 or maybe a little bit afterwards. So a round of applause again for our speakers. Thank you.
I have it somewhere there. It's somewhere